Welcome to the Radon Smart Review GI Cancer series.
Great to be back.
Today, we're wrapping up our liver mini-series. We're shifting focus a bit from hepatocellular carcinoma.
Which we spend a good amount of time on, and rightly so.
Exactly. Very crucial. But today, it's a detailed look at biliary cancers and, importantly, the management of liver metastases.
Yeah, because the liver, it's such a complex organ.
Right.
It's not just primary cancers like HCC. It's maybe even more often a landing spot for mets from elsewhere.
Makes it a central challenge for us, doesn't it?
Absolutely. That dual blood supply, its role in circulation, it's prime real estate, unfortunately.
So today's plan.
Okay, two main goals. First, we'll really dig into biliary tract cancers. That's gallbladder cancer and cholangiocarcinoma.
And we'll focus on.
We're really going to hone in on the patterns of failure. Understanding how these cancers tend to recur after treatment is, well, it's fundamental for deciding on adjuvant radiation.
Especially for these aggressive ones.
Yeah.
Makes sense. And the second part.
Then we pivot to a really common scenario, managing colorectal liver metastases, MCRT.
Huge topic. We see it all the time.
Exactly. And we'll break down the role of SBRT, stereotactic body radiation therapy.
Yeah.
Where does it fit with other local therapies?
Okay, great. So let's start with just setting the stage. The liver's role, the nature of these biliary cancers.
Right. So the liver, it's a powerhouse, doing everything from metabolism, detoxification, making proteins, producing bile.
Essential stuff.
Totally. But that high vascularity, that intense metabolic activity, it also makes it a hotspot for cancer, both primary, like within the biliary tree.
And those incoming metastases we mentioned?
Precisely. Now, biliary tract cancers specifically, they're rarer than some other GI cancers, but they are known for being, well, pretty aggressive.
Often caught late, too.
Yeah, that definitely contributes to the challenge. And while, a deep dive into the liver's anatomy, the biliary tree branching, the specific risk factors like PSE for cholangio or chronic inflammation for gallbladder,
Yeah.
that's all foundational.
Super important background, yes.
But for today, we're really zeroing in on how we characterize them and, critically, how we treat them based on the evidence.
Got it. So characterization, that means the workup, right? Can't treat what you don't understand.
Exactly. The diagnostic workup is absolutely paramount. It starts with imaging.
CT scans.
CTs are usually first up. Great for that initial overview, staging, looking for obvious distant disease.
Then MRI.
MRI gives you that superior soft tissue detail. Really helpful for looking closely at the liver lesions themselves, mapping out the biliary tree, understanding the local extent.
And PET CT.
Often indispensable. It shows you the metabolic activity, helps find occult disease elsewhere that might just completely change the treatment plan. Really defines the overall burden.
So imaging gives us a picture, but sometimes you need more, right? Like EUS?
Precisely. Endoscopic ultrasound, EUS, is crucial, especially for those parallel and distal cholangiocarcinomas.
Why EUS specifically?
It gives incredibly detailed high-res images right up close, biliary tract, pancreas, nearby nodes, and you can do targeted biopsies, FNAs.
So getting that tissue diagnosis.
Right. It confirms the cancer, helps assess local invasion, and really informs resectability.
And all this feeds into staging.
Absolutely. The workup drives the staging. We use systems like AJCC, though we won't get lost in the specific staging criteria for every scenario today.
But the principle is key.
The principle is key. Distinguishing resectable disease, where surgery is the potential cure, from unresectable disease.
Where the goals shift more towards local control, systemic therapy, managing symptoms.
Exactly. Optimizing quality of life when cure isn't on the table.
And speaking of diagnosis, that pathology report, it's the bedrock, isn't it?
It's the non-negotiable truth. You need that tissue. Is it primary biliary cancer, like an adeno,
Yeah.
or is it metastatic disease?
And it's not just what it is, but its characteristics.
Right. The histology, maybe molecular features down the line.
Yeah.
It all guides treatment. Even if we're not diving deep into specific markers today, pathology informs everything, validates imaging, tells us about potential behavior.
Without it, you're flying blind.
Pretty much. Okay, so with that foundation, let's get into our first big topic, managing biliary tract cancers.
And the stark reality here.
The stark reality is that surgical resection, offers the only potential chance for a cure.
That's a critical point to always keep in mind.
Absolutely. If surgery isn't possible, maybe the disease is too extensive, patient's too frail, anatomy's tricky, then our goals shift. But the potential for cure rests solely on getting it all out surgically.
Okay, so surgery is goal number one if possible, but often we're involved after surgery deciding on adjuvant therapy.
Right. And that's where understanding how these cancers tend to come back is so vital. The patterns of recurrence.
We're not guessing here, there's data.
Exactly. We look at work like that from Jarnigan and his group at Memorial Sloan Kettering. Their data gives us real insight into how these behave post-op.
And it helps us decide about adjuvant radiation, right? When and where.
Precisely. And the patterns are strikingly different depending on the specific type. Take hilar cholangiocarcinoma.
The ones near the bile duct bifurcation.
Yes. For those, the main problem is local failure. Their data showed something like 59% of recurrences were just locoregional.
Wow, nearly 60%.
Yeah. So what does that tell you? It tells you that improving local control, maybe with radiation, is paramount. That's your biggest lever.
Because if you can control the microscopic disease left behind.
You significantly impact their prognosis. The anatomy there, with tumors often stuck to vessels and ducts, means positive margins and nodal spread are common, setting the stage for local recurrence.
Okay, so for hilar cholangio, the enemy is local. Makes sense to use local therapy like radiation, but gallbladder cancer.
Gallbladder cancer. It's almost the complete opposite story. The primary failure pattern there is overwhelmingly distant, systemic.
How distant?
Their data showed 85% of recurrences were systemic. Peritoneum, lungs, other parts of the liver.
85%. That's huge.
It is. And that fundamental difference in biology is exactly why adjuvant radiation is considered much, much less often for gallbladder cancer.
Because if it's going to spread everywhere anyway.
Adding local radiation to the tumor bed might not change the overall survival much, and you introduce potential toxicity for maybe limited benefit. It's about understanding the inherent behavior.
Targeting the therapy effectively. Okay, so given those patterns, what about systemic therapies? They must be key, especially for gallbladder.
Absolutely. Systemic therapy is often the main event. Let's start with the adjuvant setting after potentially curative surgery.
This is where BILCAP comes in.
Exactly. The landmark BILCAP study, this is a big phase 3 randomized trial, patients with resected biliary tract cancer,
Okay.
randomized to either just observation
Full waiting.
or 6 months of adjuvant capecitabine. That's the oral chemotherapy pill.
Now, BILCAP had that interesting nuance, didn't it, with the analysis?
It did, and it's a great teaching point. Technically, the study was negative in the primary analysis, the intent to treat analysis.
Meaning, when you looked at everyone randomized, regardless of whether they finished the chemo?
Correct. The overall survival endpoint wasn't statistically significant in that group. Could be due to dropouts, side effects, whatever. But, and this is the crucial part when they looked at the per-protocol analysis, so only the patients who actually got the treatment as planned.
The ones who stuck with it.
There was a significant overall survival benefit. It was compelling.
So even though the main analysis was technically negative.
The per-protocol data was strong enough, clinically meaningful enough, that it led directly to the NCCN Category 1 recommendation. 6 months of adjuvant capecitabine for all resected biliary tract cancers.
That's fascinating. It really shows you need to look beyond just the headline p-values sometimes.
Absolutely. Understand the context, the clinical relevance.
Okay.
So that's adjuvant. What about advanced disease? Unresectable or metastatic?
Here we're thinking ABCO2.
You got it. The ABCO2 trial gave us the standard first-line systemic therapy. It established gemcitabine plus cisplatin gem-cis as the regimen.
Better than gemcitabine alone.
Clearly better. It improved median overall survival to almost 12 months. For patients with good performance status, gem-cis is the go-to.
And we had that mnemonic.
Right. For biliary tract cancers, gem-cis is the preferred systemic chemotherapy. Just a little hook.
Nice. Okay, so we have adjuvant CAPE, advanced gem-cis. Let's circle back to radiation. When do we add adjuvant radiation?
Based on those recurrence patterns we talked about, it really comes down to those high-risk hilar cholangiocarcinomas.
Where local failure is the big problem.
Exactly. Positive margins, involved nodes, that's where radiation can make the biggest difference. And the best prospective data we have comes from the SWOG S0809 trial.
SWOG 0809, what did that look at?
It was a phase 2 trial, specifically for high-risk patients resected extrahepatic cholangio or gallbladder cancer with those high-risk features we mentioned.
Positive margins, nodes, T3, T4.
Yep. And the design was adjuvant chemo first, usually gem-based, followed by consolidative chemoradiation.
Okay, sequencing matters. Chemo first. What was the radiation dose?
This is important. The standard dose was 45 gray and 25 fractions to the tumor bed and the elective nodes.
And for higher risk?
If there were really high-risk features, like positive margins,
Mm.
they got a boost up to 54 to 59.4 gray.
Now, the elective nodal volume, that's a key area for boards and planning. What needs to be covered?
It's pretty extensive for hilar cholangio. You're talking porta hepatis nodes right by the hilum,
Okay.
celiac nodes, SMA nodes, and often the periortics up towards the diaphragm. You need a wide net to catch potential microscopic spread.
So the takeaway from SWOG 0809.
The conclusion is that adjuvant chemoradiation is a reasonable strategy, especially for those high-risk hilar cholangiocarcinomas with positive margins or nodes delivered after systemic chemo. It's reflected in the guidelines.
Great summary of biliary. Okay, let's pivot now, shifting gears completely to colorectal liver metastases, MCRC.
Very common scenario we deal with.
Oh, absolutely. So first principle, if it's resectable.
If it's resectable, surgery remains the gold standard. Complete resection, clear margins that offers the best shot at long-term survival.
But a lot of patients aren't surgical candidates.
That's the reality. Maybe comorbidities make surgery too risky, maybe the liver disease is too widespread, or the tumors are just in tricky spots.
So for those folks, effective local therapy becomes critical.
Absolutely key. And for years, especially for smaller unresectable mets, the debate was often surgery versus thermal ablation.
Like RFA or microwave, using heat to kill the tumor.
Exactly. But we have a much clearer answer now, thanks to a really important trial.
The Dutch collision trial.
That's the one. Collision really provided clarity here.
What did they compare?
It was a randomized trial directly comparing surgery versus thermal ablation, specifically for patients with small, less than 3-centimeter colorectal liver mets.
And the outcome was pretty dramatic.
It was. The trial was stopped early. The Data Safety Monitoring Board saw a clear benefit for the ablation arm.
Stopped early usually means a strong signal.
A very strong signal. Ablation gave superior local control for these small tumors and substantially reduced morbidity and mortality compared to surgery.
Less invasive, fewer complications.
Easier recovery. And importantly, no compromise on overall survival compared to surgery.
So the implication is pretty huge.
Monumental, really. For these small, accessible colorectal liver mets, thermal ablation is now often preferred over more invasive surgery. It really changed the game for those specific lesions.
Okay, so collision boosts thermal ablation for the small, easy-to-reach ones. But where does SBRT fit in? Stereotactic body radiation therapy.
SBRT really becomes the go-to ablative option for the tumors that aren't good candidates for thermal ablation.
Like which ones?
Well, lesions bigger than 3 centimeters, for starters. Thermal ablation might struggle to cook the whole thing reliably.
Makes sense. What else?
And crucially, tumors located right up against major blood vessels, portal vein, hepatic veins.
Ah, the heat sink effect.
Exactly. That's a critical concept.
Can you explain that again? The analogy was good.
Sure. Imagine trying to boil water in a pot, but cold water is constantly flowing through the bottom. The heat just gets whisked away before the water can boil. Same idea with thermal ablation near big vessels. The rapid blood flow pulls heat away, preventing the tissue from getting hot enough, usually over 60 Celsius, to guarantee tumor destruction.
But SBRT doesn't rely on heat.
Exactly. It uses focused radiation, so it's completely unaffected by blood flow. That's a major advantage in those locations.
Perfect analogy. Any other times SBRT comes into play?
Yeah, also for tumors in locations that are just technically difficult to reach safely with surgery or even a thermal ablation probe.
Okay. But for SBRT to work, there's one absolute must.
The dose. You absolutely must deliver a truly ablative dose of radiation.
Is the evidence strong for that?
Unequivocal. Study after study shows a clear, steep dose-response relationship for SBRT in liver mets. It's not subtle.
So what's the target dose?
To get those really high local control rates, we're talking over 90%, which is what you want from an ablative treatment.
Right, aiming for eradication.
The tumor needs to receive a biologically effective dose, or BED10, of 100 grays or greater.
BED10 specifically, accounting for the large fraction size.
Correct. So think potent regimens like 60 gray in 3 fractions, or maybe 60 gray in 5 fractions. These reliably get you over that BED 100 threshold.
And underdosing.
Subablative doses. You will see inferior local control. It's predictable. You compromise the outcome. Dose is absolutely fundamental here.
Okay, that's crystal clear. Let's try and distill some of this into clinical pearls. Those key takeaways.
All right, pearl number 1, systemic therapy for biliary cancers. Remember the 2 big trials?
BealCap
For adjuvant capecitabine after resection.
and ABCO2.
For first-line GemCis in advanced disease, remember, GemCis is systemic.
Got it. Pearl number 2.
Adjuvant radiation for biliary cancers. It's selective. Most justified for high-risk Hiller cholangiocarcinoma because of that high local failure rate. Not for everyone.
Target the local therapy where the local risk is highest. Makes sense. And pearl number 3.
SBRT for colorectal liver mets. Dose matters. Aim for BED10 of at least 100 grays for durable local control. Don't undercook it.
Excellent pearls. And these feed directly into our clinical decision-making, right? How these failure patterns drive adjuvant choices in biliary cancer.
Absolutely. It's about tailoring. Hilar cholangio, high local recurrence risk, means we lean towards aggressive local therapy, like adjuvant radiation, especially with positive margins or nodes.
Our radiation fields cover that risk?
Right. But for gallbladder cancer, with that overwhelming distant failure pattern, the focus immediately shifts to systemic therapy. Local control alone won't solve the main problem.
Okay, and let's apply that decision-making to liver mets, choosing between thermal ablation and SBRT scenario time.
Let's do it. Patient 1, 2-centimeter colorectal met, peripheral right lobe, easy access, not a surgical candidate.
Okay, small, accessible collision trial comes to mind.
Exactly. Thermal ablation looks really good there. Lower morbidity, similar efficacy for small lesions compared to surgery, often the preferred choice.
Patient 2, different story. Solitary met, but it's 4 centimeters, central, right next to a big portal vein branch.
Okay, bigger lesion close to a major vessel.
Heat sink effect is a major concern for thermal ablation.
Right. Plus, ablating a large central lesion thermally carries higher risks. This is tailor-made for SBRT.
Because SBRT can deliver that high dose conformally, regardless of the nearby vessel, as long as we spare critical structures.
Precisely. It overcomes the heat sink limitation and can handle the larger size.
And patient factors always play in. Comorbidities.
Huge factor. If someone's too sick for surgery, that pushes you towards less invasive options like ablation or SBRT, even if technically resectable. It's always a balance.
Best oncologic treatment versus what the patient can tolerate.
And that's the art of it.
Okay, let's touch briefly on treatment techniques, specifically the principles of SBRT for liver mets.
So the core idea of SBRT is simple. Very high, very precise, very conformal doses.
And just a few fractions, usually 1 to 5.
Right. That's how we achieve those ablative BDs, getting local control rates up there with surgery or thermal ablation for the right patients.
But it demands incredible precision.
Absolutely. You need top-notch image guidance, daily CBCTs, maybe fiducials, to know exactly where that tumor is each day.
And managing motion is key because the liver moves with breathing.
Crucial. Whether it's breath hold, abdominal compression, gating, you have to account for that respiratory motion to hit the target accurately while sparing the surrounding healthy liver.
High dose to the target, steep fall off to protect normal tissue.
That's the essence. And while we didn't detail IMRT or VMAT specifically,
It's implied that you need those sophisticated techniques to shape the dose so precisely.
exactly. That technology lets us paint the dose onto the tumor while keeping the dose to the normal liver, the gut, etc., as low as possible. That's vital for safety.
All right, theory covered. Let's test it with the board blitz. Ready?
Let's do it.
Case 1. 72-year-old man, jaundice, diagnosed with unresectable metastatic intrahepatic cholangiocarcinoma. Good performance status, ECOG 0. What's the standard first-line systemic therapy? A. Capecitabine mono. B. Fulfiri. C. Sorafenib. D. Gemcitabine and cisplatin.
Okay, unresectable, metastatic cholangio, good PS, that screams ADCO2, so D. Gemcitabine and cisplatin.
Rationale.
ABCO2 established GemCis as the superior regimen over Gem alone for advanced biliary tract cancer, improving survival. KB is adjuvant, Fulfiri is colorectal, Sorafenib is HCC. GemCis is the clear standard here.
Perfect. Case 2. Thinking about that Tao et al. Series on radiation for inoperable intrahepatic cholangio, what factor improved overall survival on multivariate analysis? A. Biologic equivalent dose delivered. B. Decreased tumor size. C. ECOG 0. D. Absent saddletosis.
The MD Anderson series. That one really highlighted dose response. So A, biologic equivalent dose delivered.
Why that one?
Their analysis showed a powerful link between the BD delivered and outcomes. Higher BD predicted better local control and better overall survival independently. It really supports dose escalation in this setting.
Excellent recall. Final case, case 3. 55-year-old man, history of colon cancer, now has a solitary 3-centimeter liver met. Not a surgical candidate. You're planning SBRT. To maximize local control, which dose is most appropriate? A. 30G in 5-hex. B. 40G in 5-hex. C. 50G in 10-hex. D. 60G in 5-hex.
Okay, SBRT for CRC MET, goal is maximizing local control. We need an ablative dose, BED 10 over 100 grays. Let's look at the options. 30 and 5 is too low. 45 is better, but still likely subablative. 50 and 10 is conventional fractionation, definitely not SBRT or ablative. 60 and 5.
BED for 60 and 5.
BED 10 is 60 times 1 plus 12, 10. 62.2 cool, so 132 gray, well over 100. So D, 60 gray in 5 fractions is the most appropriate ablative regimen listed.
Fantastic breakdown. Really hits home that dose point. Okay, briefly, let's touch on controversies and advances. This field keeps moving.
It really does. One big area is that ongoing evolution in local therapy for liver mets we talked about.
With trials like Collision.
Exactly. They're refining the roles. It's not just surgery versus ablation versus SBRT anymore. It's about which therapy for which your specific tumor based on size, location, vessels, patient factors.
It's becoming much more personalized, more nuanced.
Absolutely. We're constantly optimizing algorithms for the best, least morbid outcome.
And the other point was interpreting trials like BILCAP.
Yeah, that whole technically negative ITT but positive per protocol thing, it highlights the complexities. How do we translate that into practice?
It's not just about the p-value.
It forces us to critically evaluate the data, consider clinical significance, adherence, real-world factors. Evidence-based medicine involves careful interpretation, not just applying numbers blindly.
A great point about the art and science of what we do. Okay, let's wrap up with a quick summary of the key takeaways.
Sounds good. So, for biliary cancers, adjuvant setting after resection. Think BILCAP capecitabine.
Advanced disease. Think ABCO2 GEM-CIS.
For adjuvant radiation in biliary cancers, it's selective. Think high-risk killer cholangiocarcinoma, where local failure is the main threat.
And for SBRT for colorectal liver mets.
Dose, dose, dose. Aim for that BED 10 of at least 100 gray for durable local control. Don't compromise on dose.
Understanding those recurrence patterns and dose response curves is just fundamental to guiding good care here.
Absolutely essential for making informed decisions that really impact outcomes.
Okay, great discussion. What's up next in the series?
Next, we're kicking off our multi-part series on lower GI malignancies, starting with rectal cancer part 1, looking at the neoadjuvant foundations.
Excellent. And remember, for more review and practice oral boards, you can visit radoncssmartlearn.com. Be sure to subscribe to Radonc Smart Review for that next session on rectal cancer.
Thanks for tuning in.
Thanks, everyone.